Good morning, everyone. I'm Dr. Andrea Billè, thoracic surgeon from Guy's Hospital in London, and I'm going to talk about the chest drain management during COVID-19 pandemic. The SARS-CoV-2 virus, which leads to COVID-19, has been demonstrated to remain viable in aerosol form and is transmitted by droplets. During COVID-19 pandemic, chest drainage was considered a possible source of aerosol-generated particles. This represents a safety concern for patients and healthcare professionals. The indication for chest drain insertions are elective thoracic surgery, trauma patients, and iatrogenic pneumothorax. During the COVID-19 crisis, up to 40% of patients developed acute respiratory distress syndrome. These patients had to be intubated and ventilated aggressively, often causing a degree of barotrauma, and some of those patients develop a pneumothorax and prolonged air leak, and those patients require chest drain insertions. At the beginning of the pandemic, there was no specific guidance available regarding the potential risk of aerosolization of the SARS-CoV-2 virus through the chest drain in patients with active air leak. Aerosolization is likely to occur inside a drain bottle, which then escapes through the suction port of safety valve. These may represent a potentially important mode of viral transmission. Again, at the beginning of the pandemic, closed systems connected to wall suction were considered the most effective systems to reduce aerosolization. But digital systems may represent a valid alternative despite not being closed system. At the beginning of the pandemic, considering the cardiothoracic surgery department was in charge of managing elective patients and COVID-19 patients who required a chest drain, we decided to run a basic experiment to assess and evaluate the aerosolized transmissions of particles through the chest drain. We then tested the three systems available in our hospital and in 17 peripheral hospitals that refer cardiothoracic patients to us. We tested a single chamber chest drain system, a 3 chambers suction system, and also the digital drainage system. As you can see in the results, the single chamber chest drain system was confirmed to generate aerosolized particles in the canister, in the tubes, and in the connections. With the 3 chambers suction system, there were no generated aerosolized particles within the chambers, but there is still a concern regarding the safety valve, which is open to the air and may represent a way of transmission of aerosolized particles. If you look at the digital drainage system results, we didn't find any aerosolized particles generated even around the exhaust holes. And as you can see from the tables, a different suction and a different level of fluid, and there was no any aerosolized particles. So now I will introduce Ray, a medical researcher from Medela, who is going to show their results and the analysis of their system regarding the possible spread of aerosolized generated particles and viral particles.
Hi everyone, I'm Ray, Medical Research Manager from Medela, the manufacturer of Topaz Plus. Let me give you a little bit of an insight of what happens inside the Topaz device with regards to small particles, and perhaps shed light on the phenomena that Dr. Billè has seen in his experiments. So I'll first talk about the travel path of the small particles in the Topaz Plus system. Here, the blue dots represents virus-laden aerosols. Air and fluid goes into a sealed disposable single-use canister. As a safety feature, to prevent sudden pressure buildup on the healing lung, When a patient coughs, a pressure relief valve opens, triggered only by the cough. Coughing does not generate a continuous flow of aerosols, and this can possibly be negated by the constant suction. So the few aerosols that escapes would potentially stick to the topaz wall surface. This is due to the close proximity of the canister and the walls of the device. We are really talking about millimeter gaps here, and we have a recommendation to disinfect the surface after canister disposal. When air is pulled through the filter of the device, recent laboratory results from Nelson Labs, as recent as August 2020 this year, show that greater than 99.925% of virus-laden aerosol particles are actually filtered out in the filter alone. So let's have a look at how we performed the experiments, and then we'll go into the results of those. Nelson Labs in the USA performed the viral filtration efficiency test, where a high concentration of approximately 1 million virus particles, the size of 25 nanometers, was used. Aerosol droplets is created by a nebulizer. This is drawn through the test filter and through the all glass impingers. The virus that gets through the filter is then collected into the fluid and later plated for quantification. Controls are the same setup without the filter. And in setup B, we also assess the whole fully assembled device. This is the topaz canister with the filter integrated. Now, these are the results from Nelson Labs. Looking at the filter alone, where up to 1 million virus particles about the size of the hepatitis A was pushed through, here we see that we blocked greater than 99.99917% of the virus particles as the highest score there. The same is true for B, the configuration where topaz canister with the filter integrated was assessed. Also here we see a high filtration efficacy of 99.9938% as the highest score. Now, bear in mind this sort of testing is part of Nelson Labs' daily business, where face mask standards are applied, since to date there is no current test standards for filters in chest drainage devices. To summarize, new findings from Nelson Labs performed with 25 nanometer aerosol suspended particles showed filter efficacy between 99.925% to greater than 99.99917% from the filter alone, and 99.981% and greater from a fully assembled device. We expect the equivalent retention rate for a 125 nanometer size particle, which is about the size of the SARS-CoV-2 virus, to be substantially higher. We expect the equivalent retention rate for a 125 nanometer size particle through the tube and through the filter to be significantly higher still, given the far higher retention rates achieved when testing across the entire test apparatus. Now Dr. Billè will now continue on with his presentation.
So, based on our data, we decided to manage patients accordingly to the following recommendations, both elective and COVID-19 patients. For elective patients, patients electively operated on during a pandemic have posed clinical issues in terms of managing their postoperative air leak. At the beginning of the pandemic, the British Thoracic Society issued a recommendation to use closed chest drainage systems to prevent a possible escape of contaminated aerosol droplets. Unfortunately, wall suction may prolong the duration of the air leak, particularly in patients with emphysema, and it reduces postoperative mobility. Also, the safety valve will have to be occluded with potential risk of increasing intrathoracic pressure when the suction system has to be switched off from the bottle. So our solution, based on our finding, is to use digital system in elective patients. And in our institutions, patients are managed as usual. We drain on suction for the first 24 hours and then on gravity mode. After 5 to 7 days, if patients have still an air leak, they may be discharged home on a Portex bag. This is my experience during pandemic. At the beginning of the pandemic, when no data were available, I performed 30 anatomical lung resection, and every patient was connected to a wall suction. After, in June, July, I operated on 62 patients, which were connected to a TOPAS system. And as you can see from the slides, there was a significantly reduction in terms of complication, atelectasis, prolonged air leak, and readmissions in ICU due to the early mobilizations of patients with a TOPAS system, which is now our standard management of patient post-lung resection electively. Regarding the COVID-19 positive patients, during the COVID-19 crisis, up to 40% of patients developed an ARDS, and some of those patients required a chest drain insertions to manage a pneumothorax and prolonged air leak. Our solution is that drain should be connected to wall suction to maintain a closed system and minimize the spread of the aerosolized particle. But based on our evaluation, digital system may represent a valid alternative. Despite so, we always recommend to wear full PPE if you are managing a COVID-19 patient. In a paper published in the CTSNet, a possible solution mentioned to attach an antimicrobial filter to the drainage system. Unfortunately, this system has not been tested, and there's no any evidence of efficacy when the filter gets wet when the pleural fluid gets through the filter. Also, there may be a possible leak of particles in the multiple connection, and there is no monitor system of the filter function when it gets wet. So in conclusion, with single chamber chest drain system, the use of closed drainage system is mandatory. Keeping the bottle attached to wall suction will significantly limit the mobilizations of patients. In our findings, as also you can see from the Medela evidence independently done, digital system didn't show any spread of aerosolized particles. The digital system will increase the mobilizations of patients, preventing postoperative complication. And also the digital system can be used in gravity mode safely with no aerosolized particles generated. Thank you very much for your attention. And if you have any questions, you can contact us through our email addresses. Thank you very much.